Picture this. Your heart's main supply lines are completely blocked. It's a terrifying scenario, right? Now, how exactly do doctors decide whether to snake a tiny wire up into your leg or literally crack your chest open to fix it? Well, welcome to this explainer. Today, we're diving deep into the incredibly intense, high-stakes medical decision-making behind treating coronary artery disease. You know, your heart doesn't just pump blood to the rest of your body. It actually needs its own dedicated blood supply to survive. And when those absolutely crucial supply lines get clogged up with plaque, cardiologists are forced to make a life-or-death choice between two drastically different approaches to get that flow moving again. Okay, so here's how we're going to break this all down today. First, fixing blocked heart arteries, then angioplasty and stents, followed by bypass surgery. After that, we'll weigh stent versus bypass, look into the hybrid surgery, and wrap up with the post-surgery balancing act. All right, section 1, fixing blocked heart arteries, or as I like to call it, the ultimate plumbing problem. To really grasp where we're at today, we actually have to jump back in time to 1977. This was the year the very first balloon angioplasty was performed over in Switzerland by Dr. Andreas Grinzig. Now you have to understand, before this moment, treating a blocked artery meant major open chest surgery. Period. There was no other way. But Grinzig proved that you could actually open a narrowed vessel from the inside out. This single, brilliant innovation spread like wildfire and sparked a rapid evolution in minimally invasive tools. It completely transformed cardiovascular medicine over the last few decades and gave us our very first major alternative to the scalpel. Moving right along to section 2, angioplasty and stents. Let's introduce contender 1, PCI. Let's meet this first heavy-hitting option for clearing those blockages. In the medical world, it goes by PCI, or Percutaneous Coronary Intervention. Yeah, it's definitely a mouthful, but let's demystify it a bit. Percutaneous simply means gaining access through the skin. So instead of opening up the chest wall, an interventional cardiologist just makes a tiny puncture in a peripheral artery, usually down in the groin or the wrist, and uses that as a literal gateway to travel up to the heart. It's a seriously elegant, non-surgical solution to a very mechanical problem.
So how does this actually work in practice? Well, once they gain access, a super flexible catheter is guided all the way to the blockage, navigating the blood vessels using real-time X-ray imaging. Right at the tip of this catheter is a tiny, deflated balloon, and it's covered by a collapsed little wire mesh tube. That's the stent. When it finally reaches the blockage, the doctor inflates the balloon, literally crushing that nasty cholesterol-filled plaque right against the artery walls. Then, the balloon is deflated and pulled out, but the stent is left behind as a permanent structural scaffold to prop the artery open. And here's the really cool part. Modern PCI uses what we call drug-eluting stents. They're coated with specific medications that slowly release over time. Why? Because the body treats that metal stent like a splinter, an injury, and tries to grow scar tissue over it. That special medication actually stops the tissue from growing back and reblocking the artery. A real game changer.
Next up, section 3. Bypass surgery or contender 2, CABG. Now we introduce the second major treatment pathway, known as CABG, or Coronary Artery Bypass Grafting. This is the traditional, highly invasive, open-heart surgery you've probably heard about. See, instead of trying to clear out the existing blocked pipe from the inside, surgeons take a totally different approach. They just leave the blockage exactly where it is. Instead, they harvest a healthy blood vessel from another part of your body, like a vein from your leg or an artery from your chest wall, and physically stitch it into place. They are essentially building a brand new detour around the traffic jam to restore blood flow to the starving heart muscle downstream. Which brings us to section 4, stent versus bypass, the ultimate medical showdown. Now, what's genuinely fascinating here is how definitively the medical community views this choice when cases get really severe. Take a look at this quote from Dr. Donald E. Cutlip, a top revascularization expert at Harvard Health. For a long time, there was this fierce, ongoing debate about which method was actually superior. But as Dr. Cutlip points out, for patients suffering from severe multivessel disease, which means blockages in all 3 of the heart's main arteries, the debate is pretty much settled. Bypass surgery is statistically the hands-down better option for long-term survival, assuming the patient isn't too high risk for such a massive surgery. But to truly grasp why the bypass so often takes the win, you have to understand that all coronary arteries are absolutely not created equal. The biggest, most critical one is the LAD, the left anterior descending artery. It supplies blood to the entire front wall of the heart. That is a massive amount of heart muscle, folks. A blockage here is incredibly dangerous. In fact, it's notoriously called the widowmaker. If the LED is blocked, the scales tip heavily toward a bypass. Why? Because surgeons can use the mammary artery from the inside of your chest wall to bypass the LED. And for reasons doctors still don't completely understand, mammary artery grafts are basically bulletproof. They are nearly immune to future blockages and can last for decades, offering a permanent fix that a localized tiny stent just can't match. And this breakdown right here brilliantly illustrates the strategic puzzle doctors are constantly trying to solve. It's a massive game of trade-offs. Stents are minimally invasive, you're literally awake during the procedure, and recovery is incredibly fast. They are absolutely the go-to for 1 or 2 blocked vessels, especially if that critical LED isn't involved. Bypass, on the other hand, is a major trauma to the body, requiring a split sternum and a grueling recovery. But it absolutely wins on extreme durability. It's also the proven superior choice for diabetics and patients with heart failure. So doctors really have to weigh the immediate physical toll of a huge surgery against the long-term risk of a patient needing repeat stent procedures down the line.
All right, Section 5, the hybrid surgery alternative. This is all about getting the best of both worlds. So ask yourself, what if you literally didn't have to choose? What if you could combine the decades-long durability of a mammary artery bypass with the swift, practically painless recovery of a stent? Well, enter HCR, hybrid coronary revascularization. This is a relatively new, incredibly innovative compromise. It physically brings both the cardiac surgeon and the interventional cardiologist into one specialized hybrid operating room that's fully loaded with advanced X-ray technology.
Just look at the difference in impact on the patient. Traditional CABG requires literally sawing the sternum entirely in half. It means a much longer time on a breathing tube, higher bleeding risk, and a generally rough recovery. But the hybrid approach, it completely changes the game. The surgeon accesses the heart through a much smaller incision right between the ribs to attach that ultra-durable mammary artery to the critical LAD. Then, while the patient is still right there on the table, the cardiologist snakes a catheter up to place stents in the remaining less critical blocked arteries. You completely avoid splitting the chest bone. Studies like a major one out of Fuwai Hospital in Beijing show this leads to significantly shorter ICU stays, way less need for blood transfusions, and vastly quicker recovery times. Finally, let's jump into Section 6, the Post-Surgery Balancing Act. What happens in the aftermath? You know, getting the stent placed is rarely the end of the story. Once a patient leaves the table with a brand new stent, they basically enter this high-stakes medical tightrope walk. The core issue is that a stent is a piece of foreign, bare metal sitting right inside a blood vessel. Until your body naturally grows a smooth layer of cells over it, a process called endothelialization, that metal acts like a total magnet for blood clots. And a clot forming inside a stent, that is a catastrophic, often fatal event called stent thrombosis. To prevent this, patients must immediately start DAPT, or dual antiplatelet therapy. This means taking aspirin along with a second, super potent blood thinner to keep the blood incredibly slippery and stop platelets from clumping up on that metal mesh. But here is the massive dilemma cardiologists face every day. You have to keep the blood thin enough to prevent a lethal clot in the heart, but thick enough to prevent dangerous internal bleeding somewhere else in the body. Aspirin and blood thinners are notoriously hard on the gastrointestinal tract. Prolonged use can actually cause severe, life-threatening stomach hemorrhages. So the burning million-dollar question in cardiology is, how soon can we safely take a patient off that second blood thinner? To figure that out, doctors have to carefully look at a patient's individual bleeding risk profile. According to guidelines from the Cleveland Clinic, there are several huge red flags that push doctors to shorten the duration of those blood thinners. If a patient is over 75, has a history of major bleeding or stroke, suffers from chronic kidney disease, or already has a low platelet count, well, keeping them on heavy blood thinners for a full year is just incredibly dangerous. The risk of them bleeding out internally actually starts to outweigh the risk of the stent clotting. So to take the guesswork out of this incredibly delicate balancing act, cardiologists use a very specific numeric threshold called the DAPT score. And the magic number they are zeroing in on? It's exactly 2. Here's how that score actually directs the game plan. If a patient's score is 2 or higher, it means the risk of a heart attack or stent clot is high, so they're staying on dual blood thinners for the long haul to be safe. But if the score is less than 2, it signals that their bleeding risk is actually the greater threat. And here's the good news. Thanks to modern second-generation drug-eluting stents that heal way faster, major clinical trials have proven that for these high bleeding risk patients, it is completely safe to stop the dual therapy at just 3 months. After that, they just stay on a lifelong low-dose aspirin.
Which really brings us to the future of treating the heart. I mean, think about it. We've gone from cracking chests open for every major blockage, to snaking little wires through the wrist, to these incredible hybrid surgeries that literally offer the best of both worlds, all while carefully balancing a patient's blood chemistry. As bioabsorbable stents, advanced drug coatings, and even robotics continue to evolve at lightning speed, we really have to ask, will traditional open-heart bypass surgery eventually become a total medical relic of the past? Or will the sheer incredible complexity of the human heart always demand a surgeon's manual, hands-on overhaul? It's an absolutely fascinating frontier, and thankfully, the tools we use to save our most vital organ are only getting smarter by the day. Thanks for joining me on this explainer.